This topic is cervical ripening and labor induction. I think we need to first talk about cervical ripening. This normally happens before labor. When the cervix ripens, it becomes soft, thins, and shortens for effacement and then can distend for dilation. Prostaglandins can cause this ripening. Medical cervical ripening is done to increase the client's chance of delivering vaginally, and it can be done in different ways. We'll discuss these throughout the video. It can be done with pharmacological agents, with prostaglandin derivatives, misoprostol and dinoprostone, or mechanically with a transcervical catheter, an inflated urinary catheter. Labor induction or augmentation can be done with an amniotomy, and we'll talk about that later, oxytocin, which is a hormone that comes from the posterior pituitary gland, but a synthetic form can be administered to induce labor. It causes uterine smooth muscle contractions, and it can assist with labor that is progressing too slowly. And natural alternative methods, which again we will discuss later. The Bishop score. This is an assessment tool predicting cervical favorability and readiness for the induction of labor. The more cervical ripeness, the more likely you will have success with induction. It is a 13-point scale assessing cervical consistency, position, dilation, effacement, and station. We'll look more closely at these categories in a moment. It is performed via vaginal examination, and this is done before administering cervical ripening agents or inducing labor. A score equal to or greater than 8 shows an increased likelihood of successful induction that results in vaginal birth. You can see in this diagram the categories, the different options and levels, and then the score associated with that assessment. Consistency. Firm, medium, or soft, the different positions of the cervix, the amount of dilation in centimeters, the percent of effacement, and the station. Remember, a score equal to or greater than 8 shows an increased likelihood of successful induction that results in vaginal birth. Cervical ripening. Let's take a closer look at how cervical ripening can be achieved. First, chemically, with prostaglandin derivatives, misoprostol and dinoprostone. Both cause cervical ripening and can stimulate contractions of the uterus. Misoprostol can be administered orally or vaginally, and it is given every 3 to 6 hours until the cervix is adequately soft or labor occurs. Dinoprostone is administered as a vaginal insert, as pictured here, or as an intracervical gel. For both applications of dinoprostone, the client will remain supine for a specific time frame to allow the medication to take proper effect. For both of these medications, we will monitor the fetal heart rate and have terbutaline, a tocolytic, available, which can be administered for uterine tachysystole, which is more than 5 contractions in 10 minutes. Cervical ripening can also be done mechanically with a transcervical catheter, an inflated urinary catheter. The catheter is placed manually into the cervix, and then the balloon is inflated with 30 to 50 milliliters of fluid. It causes the lower uterine segment and cervix to stretch, causing the release of the mother's own prostaglandins. Hygroscopic dilator. These are placed in the cervical canal, and it absorbs the fluid that is around it. As the fluid is absorbed, the dilator expands, causing mechanical dilation of the cervix, resulting in the release of maternal prostaglandin. One example is laminaria, made from desiccated seaweed. Chemical cervical ripening, adverse effects of misoprostol and dinoprostone. Uterine tachysystole, which means more than 5 contractions in 10 minutes. This is a problem because during contractions, oxygen is decreased to the fetus. With uterine tachysystole, the repeated contractions can cause continued oxygen deprivation, leading to complications for the fetus. For the laboring client, it can lead to uterine rupture, resulting in hemorrhage. These are contraindicated for clients with previous uterine surgery or cesarean birth, due to the risk associated with uterine tachysystole leading to rupture. Also for clients with non-reassuring fetal heart rate. Elective versus medical induction. Elective induction, when labor is started with no medical indication, not waiting for spontaneous labor to start. Elective induction is a client's choice. The client must achieve 39 completed weeks of pregnancy. Ideally, the client will have a favorable cervix, a cervix that is ready for labor and then ready for the delivery of the fetus. Medical induction. Here are some examples of maternal or fetal indications to artificially expedite labor. Gestational hypertension, leading to preeclampsia. The fetus needs to be delivered to prevent eclampsia. Cholestasis of pregnancy, reduced or blocked flow of the bile duct, which will cause maternal and fetal complications. Gestational diabetes mellitus, potentially causing complications for the fetus. Post-dates pregnancy, that's pregnancy that lasts 42 weeks gestation, which can lead to other complications like macrosomia. Another indication for medical induction is oligohydramnios, where there is not enough amniotic fluid. This may cause fetal growth restriction. And another indication is fetal demise. Labor induction contraindications. These may cause maternal and or fetal complications if labor is induced. Umbilical cord prolapse, with the umbilical cord potentially being compressed during labor and delivery, impeding flow of blood and oxygen delivery to the fetus during birth. Vasa previa, when unprotected vessels of the umbilical cord are attached or located by the opening of the uterus. These vessels are at risk for rupture during labor and potentially causing extensive blood loss. Placenta previa, where the placenta covers the cervix. Prior cesarean birth with vertical uterine incision due to the increased risk for uterine rupture. Active genital herpes infection due to the risk of passing herpes onto the fetus during delivery. Prior myomectomy, a surgical procedure to remove fibroids of the uterus. So there has been previous surgery on the uterus, causing scar tissue and increasing the risk for uterine rupture. And transverse fetal position. Nursing interventions for induction of labor. Maternal and fetal assessment prior to administering any substances for cervical ripening or induction of labor. You want a baseline and you want to make sure there are no contraindications for induction. This assessment will include vital signs and reactive non-stress test to assess the fetus. A reactive non-stress test means the fetus is oxygenated and reacting as expected. Ensure the client has signed the consent forms as required by the facility. Some facilities require different consent forms for different treatments and procedures. And discuss the plan of care with the client and their partner. Amniotomy. This is the artificial rupture of membranes. You can see how the procedure is performed in the image. A sterile tool is inserted by the healthcare provider, and the tool is used to tear the membranes of the amniotic sac. It is performed by a healthcare provider to augment or induce labor. It is outside of the nursing scope of practice. This may cause umbilical cord prolapse, which may cause fetal complications. Nursing interventions for an amniotomy. Ensure the client consents to the procedure. Assess the fetal heart rate before and after the procedure to assess a baseline, determine how the fetus reacted to the procedure, and then to continue to assess the fetus. Monitor the maternal temperature every 2 hours to monitor for infection. The presence of the amniotic sac provides protection from bacteria. After rupture, the risk for infection is increased. Note and document the amniotic fluid characteristics, the color, the amount, the odor, if blood is present, and assist the client to an upright position. This will encourage the fetal head to remain applied to the cervix, to remain engaged. And frequent perineal care. This may increase maternal comfort and will help prevent infection. And offer the client disposable underwear and pads for comfort. Natural alternative induction methods. Amniotic membrane sweep. A finger is inserted and rotated completely around to separate the membranes from the cervical wall and the lower uterine segment. It releases prostaglandins and oxytocin, inducing labor. Nipple stimulation, which causes endogenous, maternal oxytocin release from the pituitary gland. This stimulates uterine contractions and cervical ripening. Sexual intercourse. Semen contains prostaglandins, and the female orgasm stimulates contractions. Castor oil with blue cohosh may stimulate labor, and evening primrose oil with black cohosh may be used for cervical ripening. Acupuncture. Precise locations have been identified that will cause uterine contractions and cervical dilation. Amnioinfusion. This is the installation of fluid into the uterine cavity. This is done to relieve persistent, recurrent, variable decelerations caused by umbilical cord compression due to low or no amniotic fluid volume. When there isn't enough amniotic fluid for the fetus to float, the umbilical cord may become compressed during movement of the fetus and during contractions. Sterile 0.9 sodium chloride or lactated Ringer solution is administered via intrauterine pressure catheter. Complications. Uterine overdistension if too much fluid is instilled, increasing the risk for uterine rupture. Contraindications include multifetal gestation and any contraindications for vaginal delivery, placenta previa, vasa previa, placental abruption when the placenta pulls away from the uterine wall before the fetus is born. Polyhydramnios when there is an excessive amount of amniotic fluid. And intraamniotic infection, because amnioinfusion may cause the infection to worsen or cause an infection to become systemic for the fetus or the mother. Nursing interventions for amnioinfusion. Administer the fluid via infusion pump. This will assist with controlling the rate of the infusion and also provide an accurate amount of how much fluid is instilled. Evaluate the fluid return frequently. The fluid infused should ideally be the same amount of fluid that is returned. And monitor uterine tone closely for overfilling of the uterus, which may result in increased uterine tone. If an elevated uterine resting tone is noted and minimal to absent fluid return, pause the infusion and notify the healthcare provider.